Thank you very much, Nick, for that very glowing introduction. And yeah, as clinical lead, just acknowledge all of Nick's efforts in putting this whole week together, because he's done a fantastic amount of work behind the scenes trying to put this all together. And I think so far, from what we've heard, people have been enjoying it. So yeah, no, I've been asked to talk about knee surgery, trying to explain what I do for a living and what I've done at the Trust for the last 15 years in 30 minutes is a little bit tricky. But I'll do my best to whiz through some stuff, and then hopefully we'll have a bit of question and answers, and then we'll move through to patient examination and some injection techniques afterwards. So all I do is knees. I do some trauma on-call stuff, but outside of that, that's all I do. It's all I've ever done. And as does my colleague Andy Legg, who we appointed when some of you may remember Amanda Rees retired about 5 or 6 years ago. And we run this service, which hopefully you'll find of some benefit to your patients. We're going to talk about that service a little bit, some of the common conditions and the treatment options that we've got available, that not necessarily everybody does, and then some of the questions, and we'll go through the other bits afterwards. So we have an acute knee injury clinic, which I recognise some faces in the audience most people will be familiar with, which we run every Thursday at the Park Rehab Centre. Which is, again, a fantastic sort of facility that we're very lucky to have in Rotherham, with an amazing gym, a fantastic hydro pool. So it's a really good rehab centre that I personally think is underutilised and could be utilised regionally as a centre of excellence for all sorts of reasons. And we have our elective knee clinics, and we will basically deal with anything that's knee related, with the exception of bone tumours. And nobody in the region does bone tumours. They all go to 3 centres in the UK. So we can start the investigation and begin the process, but we don't treat them and manage them. Okay. And that involves both preservation as well as arthroplasty surgery. So we'll take referrals to the acute knee injury clinic according to relatively strict criteria. We run it alongside my physiotherapy colleagues, and that MDT approach really helps, I think, make sure we're all singing from the same hymn sheet, patients know where we're going, and it's been quite transformative since we've moved down there about three years ago, I'm going to say. We'll take they have to have hand injury, okay, so it's not just a dumping ground for all acute knee pain, okay, it's an injury clinic, so you know your flare of OA or your gout and all these sorts of things, query septic arthritis, you know, that doesn't get in. It's when they've had an injury within the last 3 months, less than 60 years old, primarily because what we're trying to do is pick up conditions which need early surgical management. And on the whole, once I'm afraid we reach retirement age, that becomes less onerous, if you like. We don't tend to undertake that in that sort of age group. And they must have had an AP lateral and a skyline. So if you do send patients for an X-ray, do put separately skyline view, because they don't necessarily get that automatically. And the reason it exists is, you know, in 1996, Steve Bollen, who was a consultant in Bradford, now retired, he published a good paper which basically showed in the UK, the average time from someone injuring their knee with an ACL rupture to subsequently being diagnosed correctly was almost 2 years. You know, that's an awful lot of time, particularly when we worry about subsequent injuries. And we know that patients that are treated non-operatively with ACL injuries, for instance, have around a 60% chance of coming back within that 2-year period with additional damage to the knee, like a cartilage tear. So almost all patients at that point had had an ACL rupture, and we were having to deal with other cartilage problems as well. And that has knock-on effects in terms of secondary arthritic changes. That's not to say that anything I can guarantee, anything I do guarantees people won't develop that. When you've had a nasty injury to the knee, you can always develop post-traumatic arthritis. But the idea of trying to pick stuff up early and managing it early is we can hopefully reduce that risk. Porteous down in Southampton has now shown that in their acute knee injury clinic, it's got them down to a 4.3-month average time to diagnosis, and we audited it here, and we're less than 6 months. I can't remember exactly what the number was. So that's of the whole community that we end up treating for ACL ruptures. But most of the common stuff we deal is meniscal tears. We've all got patients with meniscal tears. We're going to talk a little bit about arthritic problems, unicompartmental pain, and a little bit about ligamentous injuries as well. Now, we all know a knee that's effused and sore and uncomfortable is an unhappy knee. Sometimes that's due to a meniscal tear. They tend to have classical signs and symptoms, not necessarily where you might expect, and we'll come on to that in the examination technique. And we're really looking for those intermittent mechanical entrapment symptoms, because surgery for meniscal tears does work, despite what some have tried to suggest in the past. Our knee injury clinic principally probably exists to detect the large bucket handle tear that's fairly acute, that can be repaired, and they present with a locked knee that doesn't go fully straight, not one that doesn't bend. All knees will bend unless they're painful, but that doesn't matter. It's an inability to extend the knee. And that's because there's a blood supply that comes to the meniscus from the periphery. And if we have a peripheral tear here and we stitch it together, it will probably heal. About 20% don't, but 80% do. But only if we get them early. And once you get beyond sort of 3 months after their injury, they're much less likely, even if they're peripheral, and often the tear has been displaced for a period of time. It's undergone what we call plastic deformation. It can't be reduced, just like a fracture that won't sit in the right place, and therefore you end up having to excise it. And a combination of an ACL rupture with an excised bucket handle tear of your meniscus will give you X-ray evidence of arthritis within 15 years. Degenerative meniscal tears, we tend to try and treat non-operatively in the first instance, as all the guidance has always said, and as we have always done. But sadly, you'll know probably of lots of patients, and maybe even friends or family, who've had their knees washed out by varying surgeons over the years, and then they end up having their new knee later on. Well, a knee washout for arthritis clearly is not the way forwards, never was, and that's what's given arthroscopic knee surgery potentially a bad reputation. But when there's no arthritic change and you've got entrapment of tissue, then an arthroscopy works really well and gets people back to work much quicker. Now, we obviously do a lot of ligament reconstruction work. All our ACL reconstructions are day case. Again, you might think, well, that's no surprise, but actually when I started 15 years ago, no one was done as a day case, okay? But they all go done as day case, go home the same day. We get around 85–90% of patients get back to their pre-injury status. We've audited that. And we've got a great team of physios that obviously are key to making sure that happens. But we'll deal with MPFL, medial patellofemoral ligaments, posterior cruciate ligaments, lateral-sided instability, medial-sided instability. But the key to all of this is early diagnosis, because a lot of what we do is about bracing people correctly in the first instance, managing them and rehabilitating them properly. And then sometimes we can even avoid certain operations that are not necessarily required. And we've seen throughout the UK, because of the introduction of acute knee injury clinic, the number of PCL reconstructions, for instance, has dropped off dramatically, because we're bracing them properly and treating them non-operatively. The PCL, I know this might sound a bit bizarre, is an extra articular structure. It has a blood supply. It can heal if it's treated correctly, unlike the ACL, which doesn't. So then we'll talk a little bit about unicompartmental pain and arthritis. And just like the tyre that's malaligned, if you're bow-legged or knock-kneed, you'll wear out one side of your knee rather than the other. That doesn't necessarily mean if you send a patient for an X-ray and you get an X-ray report back that says you've got arthritis, that the only option is a new knee. Okay, there are alternatives. So you might get a scan, which I'd rather people didn't, because if the X-ray tells you all you need to know, the scan will tell me there's a meniscal tear, but this patient does not need an arthroscopy. They've got established arthritis with a meniscal tear. An X-ray would have told me that, not an MRI scan. So then we'd have got some alignment views. We can drop a plumb line from the centre of the hip down to the centre of the ankle. And we can see that all of the weight goes through the medial side of the knee. I haven't put the plumb line down this side, but you can probably visualise that it's more central on that side. So we might think about doing an osteotomy, for instance. And we do quite a lot of osteotomies, more than anywhere else in the region, I believe. And classically, for the vast majority of cases, that's because they are slightly varus or bow-legged, and they get a high tibial osteotomy, where we essentially break the bone. That's what we tell the patients. It's not easy for us to sell this as an operation, as you can probably imagine. But then when I say, well, look, any other type of operation, whether it comes to any sort of joint replacement, involves a saw and cutting through bone. And then when they realise that, they realise, oh, yeah, okay, I suppose I get that. So yeah, we cut through the bone. It's a biplane osteotomy, so it's relatively stable. And into this defect, normally I put something called a wedge allograft, or a piece of dead person's bone, which acts as good structural support and comes in pre-shaped wedges. So when we've calculated the correction that's required, we get it right every time. In someone that's knock-kneed or valgus, then we tend to do a distal femoral osteotomy. You can see how they've changed through a weight-bearing axis through the lateral side of their knee, and then it's going through the more central portion. And rarely, in really severe deformities, we might even consider, so this one you can see is sort of going through fresh air, it's not even going through the joint, doing a double level osteotomy where we have to do a correction above and below in order to keep the joint line perpendicular to the floor. An osteotomy works well. You might think, well, you know, it's a barbaric operation that went out with the Dark Ages. It did fall out of favour, but it fell out of favour primarily because people in the past were using somewhat weaker plate constructs. They often broke. The osteotomy site often collapsed. It made the subsequent knee replacement surgery difficult. And therefore, to some of my colleagues who might have been around 10 years plus before me, they kind of left that as a treatment option to one side. But we just don't see that as a complication now. And actually, we can see their scores improve markedly from pre and post-op. I think the Blues boys and the Reds girls. And I've certainly had patients, I've done a double level osteotomy, and who emailed me many years ago now to say, for the first time in my life, I can run with zero pain. And that's the nice thing about an osteotomy in a younger patient. If they want to go out and hammer their knees, they can, because their knees are already a bit buggered, but they actually manage to do really quite well with that and can maintain a very active lifestyle, the sort of lifestyle that they wouldn't be able to do with a joint replacement of any description. Briefly, we also perhaps sometimes see people who do develop what we call post-meniscectomy syndrome. So they end up having part of their meniscus or all of their meniscus removed, and they can still get pain and discomfort, and that's the sign of an early failing knee. That's already too far gone, but occasionally you'll get somebody whose chondral surfaces are actually in pretty good shape, but they've lost their meniscus. And these days we're now using meniscal transplants as a treatment option. We're the only hospital in South Yorkshire to do that at the moment. Leeds, I think, is the only one in North Yorkshire that does it. It's becoming a very well recognised treatment. Myself and Andy do them as combined cases. We haven't done lots. We've probably done about 6 or 7, but we got an email through yesterday that we've got 5 that are matched, because these patients have to be scanned. Their anatomy has to be matched to a donor, and those donors usually come from the States. And usually younger patients that have been involved in road traffic accidents, that sort of thing. So, one option for unicompartmental arthritis is an osteotomy, and then we all know there are 2 other options. But before we get to that, we mustn't ever forget that there are non-operative approaches to arthritis, all of which, again, we do, and we advise patients accordingly. Braces, injection therapies, primarily just steroids. I tend to steer clear of PRP injections. I haven't really seen the evidence to support that, certainly in the weight-bearing joint like the knee. And I'd like to think that most people have been through this process before they come and see us. Occasionally arthroscopic surgery for a degenerate knee is appropriate, but only very occasionally, and only if you're in a position where you can do the next operation, not if you're in a position not to do that, i.e., you know, all you can do is a knee replacement and you don't want to do that, so, you know, don't do the arthroscopy. But yeah, people want to maintain a normal active lifestyle and delay their knee replacement. And particularly the sort of middle-aged kind of guy like me, between 35 and 60, that's where this grey area sits. And people worry about having a knee replacement, rightly so. It's a major operation, which if it goes wrong, goes dreadfully wrong. But the question is, should we be doing knee replacements for patients in their 40s and 50s? Because they often say, I want my life now, or not in 20 years. And I hope you don't mind me asking, are there any GPs in the audience that are prepared to stick their hand up? Yeah, go on then. If I could ask you, if you see a patient that comes, you've sent them from X-ray, the X-ray comes back with some arthritis, they're 55, 60, and you think, well, I need a new knee. What do you tell them how long they last for?
Not really sure. I said they're not going to last forever.
Okay. No, that's fine. So you wouldn't tell them anything. You'd say, I'm not sure. Okay. Would you tell them anything? Sorry, you said you were a GP. Do you tell them how long they last for?
No, I don't think I would comment on that, but I have seen elderly patients who have had knee replacements for years.
Yeah.
They are still okay
Anybody else want to hazard a guess? How long would they say to any of their patients how long knee replacements last for on average? No? Yeah, okay. So you said the classic thing, and that's every patient comes to me and they always tell me, my GP told me they'd last for about 15, 20 years. And GPs do say that, even though I'm sure you two don't. But it's complete rubbish. We look at the National Joint Registry. That's how we get our data. The National Joint Registry is a massive database. It's been going for about 20 plus years now in the UK. There's other countries do the same. Put all our implants into a database. And it churns out the survivorship of an implant at 15 and 20 years. That's why that number comes about. So in the average patient in the UK who has a knee replacement, who at the moment is about 70, maybe 69, and they are 4 or 5 years older than the average of my patients, but that's because that's what I do. But in that average patient, the risk of them needing a further operation 15 to 20 years later is only about 3%. So that means they've lasted for 97% of people. Doesn't mean they're all delighted with it. Certainly doesn't mean they're all alive. A lot of 69-year-olds aren't 15, 20 years later. But it's important to try and remember that when you're counselling patients, if you decide to put yourself in a position where you're counselling patients about surgery, I'd caution that that's perhaps not necessarily the best thing to do if you don't do the surgery. So can we reassure patients? There is new technologies out there. What should we be offering? We have to remember that a knee replacement is an internal amputation of the knee. And it's regarded by many, including myself, that it's essentially a salvage procedure. So I'm trying not to do something which is going to preclude the next stage of treatment, and always be cognizant of the fact that whatever I might do, if it goes wrong, could affect that. But sometimes you've got no alternative, and a total knee replacement is the only thing we can do. And even in younger patients, you know, the youngest knee replacement I've done is 21 years old, but they did say they would rather lose their leg. So you kind of go, well, fine, I'll do this, and then if you lose your leg, you lose your leg. And he hasn't, it's still going strong, and I did him about 10 years ago. But we used trabecular metal. I used this for younger people. It's still an area of controversy because it's more expensive, but it's a newer technology. We are starting to see some really good data now, because this is the same stuff that dentists use for dental implants. And just like your cemented knee replacement or the pointing between the bricks of your house at home, eventually the pointing needs redoing. The commonest reason for a knee replacement or a hip replacement needing to be redone is because it becomes loose, because the cement mantle starts to break and degrade. Whereas we think we can get biological fixation here where the bone grows into this metal. And we've done over 400 now, which is the largest series in the UK, and we haven't seen a single one get loose yet. We also use computer navigation sometimes if needs be. We've got different types of designs, but we're not maverick. We never sort of just play with something and then discard it. Everything, if we do adopt something new, is either part of a trial or because it's got good evidence behind it. And what can we tell patients who have a new knee what they can do? Well, they can do most of these things. I taught to say gentle golf, tennis, perhaps maximum skiing, but you're not going to be able to run and jump to keep fit, whereas you could if you had an osteotomy potentially. And again, we have to be mindful that it's not a replacement back to normal. It doesn't replace you back to how your knee used to be when you're 21. 50% only achieve, or not even that, achieve a forgotten knee. And 10 to 15, even 20% in some papers are still disappointed after a couple of years. As I said at the outset, we look at the risk of a revision operation, and that risk increases with age. So this is your typical NJR graph. These are patients that are under the age of 65. These are patients that are over the age of 75. A whole bunch of these are still alive 10 years later. A whole bunch of these are dead. So you're always going to have a mismatch. And often people think, well, it's because a younger patient uses their knee more, they're going to wear it out quicker. And I don't really think that's true personally. These days with new modern technologies and implants, I've not seen the sort of failures that I saw when I was training, whereby the polyethylene was poor, it used to crumble up and delaminate. These days that they don't. What I think seems to happen, and I use the analogy in clinic that by having a new knee is a bit like buying a new car. If you're still, if you're a retired 65, 70-year-old, get a new car, go to see the grandkids, go to the local corner shop, putting on 5,000 miles a year, that car can last you a long time. If you're 55 and you need a new car, then you're probably using it to commute, you're putting on 20,000 miles a year, and yes, it may not last as long, but you probably also don't want a Skoda. And with the greatest respect to anyone that drives a Skoda, most older people are happy with a Skoda. They just need to get from A to B. But if we're still working, we don't really want that. We want a Porsche or a Range Rover or something that's a bit nicer. But all knee replacements are Skodas. Okay, they do what they say on the tin, they're all right. So I think the problem that you have is that with a higher revision rate is you're less likely to be happy with your knee replacement when you're younger because you can't do what your other 55, 60-year-old mates are doing. So you go knocking on some doors and say, listen, this knee replacement is a bit rubbish, and you'll find someone that will redo it. So your reoperation rate's always going to be higher.
Is the trabecular metal in a Skoda?
In terms of the way that functions and the outcomes, yes. It's just it'll probably go a bit longer. So again, we look at unicompartmental knee replacements and total knee replacements, and we can see in younger patients the risk of reoperation is much greater. So we have to be cautious about offering the surgery in younger people. Even, you know, the rate of infection, bizarrely, is higher in patients under the age of 50 years in total knee replacements. So why do unicompartmental knee replacements if I've just told you that total knees do well? And everyone seems to think, not everyone, but lots of people seem to think that unicompartmental knee replacements don't last as long. Again, I'd want you to take away from this sort of thing about it's not the implant that doesn't necessarily last. And there are a number of reasons why unicompartmental knee replacement may have a slightly damaged reputation, but it's improving and increasing all the time. And as I said, a knee replacement in its entirety is effectively an amputation of the inside part of your knee. Your knee's got 3 compartments to it. If 2 compartments are healthy, why would you go amputate them? You know, you wouldn't just do an above knee amputation on someone that could manage with a below knee amputation, just because you might run the risk of having to convert it to an above knee at a later date, as an analogy. So there are some distinct advantages of doing unicompartmental knee replacement over a full knee replacement. You're 3 times more likely to have a knee which you can forget about. You've got reduced complications. All complications are less, including even death and infection. There's much less blood loss, faster rehabilitation. And about 4 years ago, because there's been such a sort of polarised opinion about knee replacements, I thought, well, let's just do them as day cases to show that it's a very different operation to a total knee replacement. And now, you know, we're doing all of them as day cases, 98% successful discharge, which we've published on. And there's also a lower cost associated with it over the patient's lifetime, because a revision of this or a redo of this operation is a much different beast to a redo of a full knee replacement where there's lots of bone loss and need a more expensive prosthesis. So this is our day case uni knee replacement leaflet, and as a consequence of that, we are now the best hospital in terms of the model hospital data having the highest day surgery discharge rate for unicompartmental knees. Now this was data that's only really come to light relatively recently, because some of you may have heard of something called GIRFT, or G-I-R-F-T. GIRFT stands for getting it right first time. That nomenclature came about because in the past people used to say, don't do a bloody unicompartmental knee replacement, get it right first time and do a total knee replacement, because they've got a higher reoperation rate. And we've, a knee surgeon, spent the last 10, 15 years trying to convince the arthroplasty guys that put together all this NJR data, look, you know, there is a place for unicompartmental knee replacement. And now they've completely changed tact and said, well, you've got to discuss that option with patients that present, and if you're doing it, you should really be doing it as a day case. So we're all sitting pretty now, according to GIRFT, but we weren't 10 years ago because they didn't like us doing unis. Because there's a higher revision rate, 12% versus 4% at 10 years. So that's 12% for unis, 4% for totals. NJR is about 7% at 10 years. What's important, though, is it's 3 times higher reoperation rate with surgeons that don't do that many, so less than 10 a year. A lot of people think that that's because those surgeons aren't as good as us. That's not true. That's not what we're saying. But it may be to do with the type of patients you're seeing, and maybe you're seeing a broader spectrum of patients. You're not as good at picking the right patient to do it on. And we know that there's still a higher reoperation rate in patients under the age of 55. So that's why I often come into that discussion with unicompartmental knee replacement, with osteotomy in that particular age demographic. But we don't have that high reoperation rate. So this is something called a funnel plot, which you may be familiar with, but probably not on the whole. But it's the sort of stuff that, as surgeons, we get beaten by every so often with a stick if we're a bit crap. And basically what this funnel plot shows is each one of these dots, there's lots of little blue dots in there, is an individual surgeon. And it tells us what that individual surgeon's reoperation rate is compared to every surgeon in the UK. So this is all knee surgeons that do unicompartmental knee replacements in the UK. And if you're above this red line, these red dots, they're called outliers, and they tend to get a letter from the chief exec or the medical director to say, come on, you need to come and speak to me because you're not doing very well and you've got a really high reoperation rate for unicompartmental knee replacements. So you need to stop doing them. If you're on the green line, you're about average, okay, which is where the vast majority of people sit. If you're below the blue line here, which is where, this is my data, and I think Andy's is pretty similar, we're in the top 5% of the UK for having the lowest reoperation rate. If you're outside here, again, people get a bit sus and think you're kind of killing your patients or doing something to stop them having a revision. So they come and have a look. So that's kind of where we want to be, down the bottom there. And that's for unicompartmental surgery. And then for Rotherham as a trust, all of our knee replacement data, again, this same funnel plot. Each of these dots is an individual trust in the country. And that green line is your average. Above that and above here, you have a high reoperation rate for your knee replacements. Down towards the bottom where we are. And here, again, it's the same sort of data, just in a different bar form. So there's the average. You don't really want to be up here. Anywhere in the green is satisfactory, but the closer you are down the bottom, the better. So as a trust, we're doing really, really well with our patients and their knees. And just to give you an example, if this will play. So this is a lady whose unicompartmental knee replacement I did about 6 weeks ago. I saw her in clinic 3 weeks after the surgery. Somebody from one of the ex-presidents of the British Association of Knee Surgeons came across to see our day surgery pathway, watched us do this surgery, and I sent her around for some imaging. So that's her 2-3 weeks down the line. She's 72, 73. Low physiological insult to the patient. She's already up mobile without crutches, doing really well. Oh, and by the way, I did replace her other knee, medial compartment, 13 years ago, and that's still going strong. So they do work, and they work well in the right hands, in the right patients. And this other guy, if it plays, is similar. No, okay, it's not playing anyway. So, in conclusion, all patients have different demands and expectations, and we need to be careful how we tailor that treatment. And you have to gain experience to offer all options. And then management's challenging. That's why I enjoy doing what I do. But if we do it well, then who knows what they can achieve. Okay, so hopefully I've dispelled a few myths, and please do shout out with any questions. Yeah. So we'll just talk a little bit about clinical examination of the knee. This talk has pretty much been put together to teach our higher surgical trainees how to examine the knee properly. So it's a bit more detailed than I would anticipate many of you needing. And the examination is difficult, actually, and it took me a while before I was confident as a trainee to sort of pick up most pathologies. And I'd still say to you that history is 9/10 of the key. You know, really, really good history. I often know what the diagnosis is before I've laid hands on them. And when it comes to sports injuries, it's those classic sort of questions that you need to ask. Did you feel a pop? Did you go down? Did you think like you'd broken your knee or you dislocated your leg? Or did you think, oh, that's all right? Did you manage to jump up and carry on? Or did you have to be carried off? Did it swell quickly? Were you able to jump out of bed the next day and go down the stairs as normal? You know, all those sorts of things give you guidance as to whether they've had a significant injury or they've just had a tweak of some description. But what I would say to you is don't ignore an effused, painful knee following an injury because it's done something. When it comes to examination, we just try and keep it simple. Just keep it global, look at things, a regional look at things, and then a local look at things, and keep practicing it. And as a broad rule, we just have this system where you stand them up, have a look, walk the patient up and down the corridor, sit them down, ask them to bend the knee, and then lie them down, and then examine them. And when we're looking at alignment, we're looking at the scars, looking at their quadriceps bulk, look for effusions and cysts, their Q angles, otherwise their quadriceps angles. So people that are slightly more valgus or knock-kneed have a higher incidence of patellofemoral issues, look at their rotational profile, look at their feet, and pick up all sorts of things. You know, alignment is often very difficult to tell when people are wearing a skirt or even a pair of loose trousers. So, you know, if you're going to do it properly, you need to get them undressed. And then we walk them up and down the corridor. We look at the type of gait they've got. Are they using any sticks or walking aids? Are they limping, or are they able to fully extend the knee? And that's why they've got a slightly bent leg, and therefore they're limping, because it's effectively a little bit shorter than the other side. And then we'll sit them down on the edge of the bed, and we'll ask them to extend their knee and flex the knee slowly whilst we look at the patella tracking. And again, patients who have patellofemoral issues often have something called a subtle J sign. So as you extend the knee, you see the kneecap come up and it rides around to the lateral side of the knee, and that means their muscles on the medial side of their thigh need to really be quite strong to engage that patella back into the groove as they flex. It also helps you look at the integrity of their extensor mechanism. And then when we lie them down, one of the first things I do is I just give the hip a quick wiggle, because it's really embarrassing when you find that your painful knee ends up being actually an arthritic hip above and you've not looked at that. And it's a common mistake that I still see a couple of times a year. Look at their quadriceps bulk, scar, swelling, look for an effusion, cysts. And you might want to quantify the quads wasting by measuring just a fixed point above a bony prominence. And then we're going to do a number of tests, perhaps for an effusion. Patella tap test most people seem to know of. The number of times I've seen medical students in their finals go along and actually physically tap the patella. Yeah, that's not what you do, by the way, in case you didn't know. You actually push the patella down, you're trying to tap it on the front of the femur. But then I even remember, this is a little anecdote, about seeing a student doing, is it Riney's and Weber's test for conductive and sensory neural deafness? You're supposed to put a tuning fork, bang the tuning fork, put it on their forehead, and then I'm seeing one student crack the patient over the head with a tuning fork. Says, "Can you feel this?" Anyway, that's by the by. So yeah, so a sweep test, this video is not playing, unfortunately, I couldn't get it to play, but you need to sweep out the fluid from the medial gutter and into the suprapatellar pouch, and then sweep up the lateral side, and you'll see that fill in with a smaller effusion. Palpate your landmarks, know where they are. A lot of people think they know where they are, but they're not. In the past, I've often got colleagues like yourselves to get up and show me how you examine a knee, but I think that's probably a bit embarrassing for some, although I'm sure knowing one or two faces, they'll know how to do it brilliantly, and therefore put the others to shame. But the joint line is not midway bent knee between the apex of the knee, i.e. the patella, and here, okay? You have to remember the tibia shaft is there and the joint line is perpendicular to that. So it kind of starts, just as you run your thumb up, you feel that little divot and it goes around towards the back. And it's important to palpate that joint line very precisely, because that really gives you a clue, particularly when it comes to meniscal tearing. And that pain you tend to find classically on the medial side is behind the MCL, so right around that back corner, it's not at the front. You might palpate tibial tubercle, looking for osgood-Schlatter's disease, looking for bursitis, and these are the sort of structures that you really want to just have a rough idea of where they are when you're feeling a knee. And then we get them to move it, look for the straight leg raise, look at their active and passive range of movement, make sure that it's similar. If it's different, document that. Look at the symmetry between the two. And particularly, I'm often looking at their hyperextension, so often I'll put a hand on their thigh and just lift their feet up and look to see how high the heel comes off the bed. And again, a knee which subtly doesn't do that is often quite a good sign to pick up on. And then we do this assessment for the cruciates and collaterals, which is where everyone gets a little bit stuck and finds it difficult to do, and that's because it is difficult. And we're always talking about endpoints, okay? So again, people often get hung up on how much it moves. That's not so important, it's how it feels, okay? With both the posterior cruciate ligament and the anterior cruciate ligament, these tests are designed to take what's effectively a bit of rope in the middle of the knee from slack to taut. And if you do that with the rope, you go dunk, okay? And that's what you can feel when you're assessing these ligaments. We talk about PCL first of all, because everyone talked at medical school how to assess for an ACL injury. Who does the anterior draw for an ACL injury? And half of you aren't going to, because most of your physios, and you know this now, but it's just a complete waste of time, and is not what we do an anterior draw for. What we're looking for is actually a posterior draw to see if the tibia's sagged back. So this guy's got a posterior injury, posterior cruciate ligament on this side. You can see how if you were to rest a pen, how it doesn't actually sit in front of the top because the shins sag back, but this one does. Okay, and then if we flick through, moving that front and back, you can see how that sags back. And you just don't feel an endpoint that does that. It just feels like it's soft. In the acute setting, it can harden up after a while once it's tried to heal. And then the test we do for an ACL injury is the Lachman's test. This might run with a bit of luck. So this is with a knee. So when we do the Lachman's test again, we're feeling with the knee. It's slightly bent at about 15 degrees, and we're basically putting a finger over the, so your thumb over the tibial tuberosity and your hand over the distal thigh, and you're lifting it forwards and trying to feel for that end point. Again, we're looking at the collaterals, both medial and lateral. That can be quite difficult and subtle to pick up in the chronic situation. In an acute situation, too sore. And then there are other various tests we might look for, like pivot shift, a dial test. But I'm not going to talk too much about those because that's a little bit more advanced. But you can sometimes get an idea for the arthritic knee by pressing down the patella onto the anterior aspects of the femur and see if that reproduces symptoms. And when I'm assessing for meniscal tests, you know, we talk about McMurray's in the books, but actually all I do is tend to put my hand on the joint line and flex them right up and rotate the foot. And if it reproduces their symptoms and they go ouch, and they've got tendons in the right place and all the other bits in the history line up, then I'll probably just go ahead and scope them rather than scan them, because a scan doesn't make people better. Dial tests, again for posterior posterolateral corner laxity. That's quite a nasty knee. So quite relevant just to make sure you do just check their distal neurovascular status, make sure they haven't got a foot drop from a perineal nerve lesion or something like that. Make sure that they're not excessively hyperlax and therefore they're much more likely to dislocate joints. These are mistakes that the trainees often make in the exam, so you don't need to worry about that. But in summary, we stand the patient, we look, and then we walk them. Then we sit them down, then we lie them down, then we do the look, feel, move special tests. It's not rocket science, but it is difficult to do this with confidence. So the history, as I say, is key, and if the history fits, then it doesn't matter what an MRI scan says or an X-ray or your examination findings are, just send them up. Thank you. The important thing is the injection gets into the knee joint. That's the key, and if it doesn't get in the knee joint and you miss, it's painful, and therefore it doesn't work, and therefore you put patients ever off having injections again. And injections, I'm not suggesting is the way to manage patients ad infinitum. And I don't want to go over other people's ground in terms of what the indications are for injections, but we can talk about that in questions if you like. But if you do decide you're going to do an injection, I'd strongly recommend that you do two things. Firstly, that you mix up that tiny wee vial that you get of Kenalog or Depomedrone with around 10 mils of 0.25% bupivacaine. Don't just inject the tiny wee vial, because if you miss, all of a sudden that 1 mil that's in that vial goes and it's gone. And you don't really know whether it's gone into the joint or not, and it's probably not. Whereas if you've got a reasonable volume, whenever you get into a joint, as you put it in, it's like squirting the needle into fresh air. You know that you're in then. You can even sometimes see the medial side of the knee fill up a little bit. So I think it's important to have a volume, and it also means it'll, you know, swizzle around inside the joint and get to where it needs to work. And it doesn't matter where it hurts at all. A lot of people are taught, particularly through physiotherapy circles, to inject through where we would tend to do arthroscopy portals at the front of the knee, in the anteromedial and anterolateral. And even one of my colleagues, who I keep having pleasant enough arguments with at a hospital, still does it that way. But whenever I'm doing an arthroscopy, if I put the scope into those portals and then look in with the camera, all I see is fat, because you go straight into the fat pad. The way we then put the scope in is I extend the knee and then I push it up underneath the patella, then I'm into the joint. Okay, so it won't end up in the knee if you use that technique. The best way to reliably end up in the knee is to use a supralateral injection portal, and that's what I would recommend you all do. It's not too challenging, it's not too difficult. You've got your fluid, you palpate your landmarks, you can feel the patella, you can even sort of rock it from side to side a little bit. I sort of feel where the superior pole of the patella is. That's the line that I'm going to inject in. And we're going to inject sort of not in a oblique fashion, but horizontally underneath that patella. So it's important to have the patella facing forwards. Then when I've got my line, I can feel where it is, and sometimes I sort of push it towards me so I can almost see the edge of the patella. And then just above that, into this little soft spot here, and underneath the rectus tendon, we're just going to slide the needle straight in and then inject all in one go and then take it out. And that really doesn't hurt patients. It's no worse than having blood taken if you get it in the right place. Now, obviously, it's a bit difficult when you first start doing that. If you go too low, you'll hit the femur. If you go too high, you may hit the patella, depending on how high above the patella you're going. But I just go for the superior pole, just underneath it and into that lateral side. And that's where we inject. Okay. Just a little bit on indications for injections, though. I will just mention, we do, as surgeons, we have a little bit of a concern about patients having lots of injections when perhaps an operation might be in their interests, because we do know that if we do any form of surgery on a knee that's been injected 100 times, that they will have a higher risk of complications. A steroid injection is an anti-inflammatory. You need an inflammatory response after surgery to promote healing. If they've got lots of steroids in there, it can diminish that body's ability to promote that inflammatory response, and therefore you have a greater instance of wound problems and infections and things like that. Having said that, we will have patients who are very anti-surgery, and that's fine, and they're not going to have an operation in a month of Sundays, in which case, fine, no problems with that. If it's on an annual basis, it's probably okay to an extent, and we've all got patients that are not fit for an operation, so that's perfectly reasonable to do so. But as a rule of thumb, what I tend to do with people who are trying to avoid an operation is I'll do this. If it works well for a few months, say at least 3 months plus, I don't mind doing it again. And as long as they're cumulatively spaced out and working for longer, then you can keep going that road. As soon as the next one doesn't work as well or really don't get much relief, then just knock it on the head and you might have to reconsider an operation. Okay.